So welcome to another series of our COVID and Kiwis interviews. We're very lucky to have Dr. Lin Chen coming in from Harvard and Boston, Massachusetts. Dr. Chen was actually supposed to come to New Zealand in March and was affected by this, the COVID pandemic. So we thought no better way for her to come virtually with this interview today. Dr. Chen and I actually worked at Mount Auburn Hospital for many years, so she's been a great friend and a mentor to me. Dr. Chen is the director of the Travel Medicine Center at Mount Auburn Hospital of Harvard Medical School. She is Associate Professor of Medicine at Harvard Medical School, and she actually is the president of the International Society of Travel Medicine. She's an expert in emerging infectious diseases, travel medicine, and tropical medicine. She has hundreds of publications and also writes for the CDC. I think this is going to be an excellent interview. I'm really excited because I think many of us have been affected by travel, what to do, and just getting more information. So welcome, Dr. Chen. Thanks for having us, having the time to talk to us today.
Thank you so much. Thank you so much, Xaviour, for the invitation, and it's nice to see you virtually. So I could not make it to New Zealand when the borders closed and flights were about to be canceled and conferences canceled at the last minute. But I thought I would start by, let me see, a little technical thing.
So we're going to do just a little background. We thought that with this particular presentation, we're going to do some slides, and I think the audience will find this extremely useful. And then we're going to do a little back and forth commentary and questions. So also, if you've got questions, send them in. We're happy to answer them on the feed with YouTube. And also click subscribe to our channel. We're going to have more of these interviews, and you can also follow us at kiwileaders.org or on the social media channels. So we're just going to try to share the screen. So if we're just going to,
let's see, is that sharing?
Yeah, that's sharing now. So
okay, so let's go to just talk about the way we were thinking about this conversation was to think about recent outbreaks with impact on travel. Then we can talk about COVID-19 updates that might be of interest to listeners, and then reflect on travel during this outbreak and as it became a pandemic. So in this very, very interconnected world that we live in, infectious diseases travel and disseminate very rapidly. To contrast with 1700s, in 1787, it took a year to travel from England to Australia by ship. Nowadays, a traveler can reach almost any major city on Earth within 24 hours. Less time, which is less time than the incubation period of most infectious diseases. And as our pandemic was playing out, I thought about the public health issues that are of interest in history. So in the 1700s, communicable diseases increasingly raised concerns as more and more people crossed the oceans from Europe to America, for example. And infectious diseases were recognized to be threats to the health of the public, the population. So in the United States, Liberty Island was the site of a hospital that held sick passengers and crew, including those infected with smallpox, cholera, and yellow fever. By 1863, the quarantine system was established in New York. And these are some of the historic pictures from that time. Then In thinking about recent outbreaks, pandemics of note, the 1918 influenza pandemic is probably the most dramatic. And most people have either heard about it or have been reminded of it recently. And this is, it really started about January of 2018. The exact origin is still unclear, although many people have called it the Spanish flu. In the United States, in March of 2018, flu-like illnesses was detected in about 100 or over 100 soldiers at a camp in Kansas. And the number of infected cases quadrupled within a week. By May of 1918. By May of 1918, the soldiers deployed to World War I brought it across the Atlantic. And in September to November, they had a second wave. It was highly fatal, and many ended in death. In January of 1919, there was a third wave that happened. And these photos remind us of some of the measures that we're employing now in confronting the COVID-19 pandemic. So the 1918 influenza pandemic actually lasted until about December of 1920. So that's nearly 36 months. The estimated number of people infected was 500 million worldwide, about a third of the world's population, and it caused 50 million deaths worldwide. And in the US, it was estimated that we had 675,000 deaths. Again, the most dramatic of all. Then what about more recently? Well, since 1918, there have been many other influenza pandemics, but then SARS coronavirus infection in 2002 to 2003 was probably the next notable one. And this particular outbreak infected over 8,000 people around the world and caused 774 deaths on record. Then influenza pandemic in 2009 into 2010 was another one where that infected an estimated 700 million to 1.4 billion people, 150,000 to 575,000 deaths. Moving on to MERS, coronavirus. This is Middle East Respiratory Syndrome coronavirus. From 2012 to 2019, this was about September 2012. And it's still lingering. So far, it has infected at least 2,500 people, caused somewhere over 800 to nearly 900 deaths. So in these recent years, SARS coronavirus and MERS coronavirus are in the same family of viruses as the coronavirus of 2019 into 2020. And then we shouldn't forget about the Ebola outbreaks in West Africa from Guinea, Sierra Leone, and involving Guinea, Sierra Leone, and Liberia from 2014 to 2016, infecting over 28,000 people, causing more than 11,000 deaths. And Zika, which is quite recent in our memory, that infected over 700,000 people in the Americas, and subsequently has gone on to cause outbreaks in Asia and Africa and elsewhere. So that one, even though there are not that many deaths that resulted from Zika, there is a long-term consequence with the congenital Zika syndrome when babies are born to women infected during the pregnancy. I did not put in here chikungunya, which is another notable outbreak in the last 10 years or so, last 15 years. that causes arthritis. So you can see that many of these major outbreaks around the world have been viruses. And now the coronavirus, our current concern. In the initial official report of severe pneumonia in Wuhan was reported to Beijing late December 30th, 2019. It was linked to the Huanan seafood market in the city. And if you follow this timeline that was put together and published in Lancet in January, this was the first cluster of cases identified. Within a couple of days, this particular seafood wholesale market was closed. And within a week, the novel coronavirus was isolated. And then within 2 weeks, the first fatal case was reported, and subsequently, it was named as 2019 novel coronavirus. Genome was sequenced, and very soon after, the first case was reported in Thailand, then in Japan, then in Korea, and explosive outbreaks followed. And then we also saw that healthcare workers were getting infected. And this grew exponentially, and the outbreak, the spread was really rapid throughout Asia, through travelers. A very, very good example of how travel connects us all around the world. And as this coronavirus started involving and affecting more and more countries crossing borders, we started to see cancellations of large gatherings, international meetings, large corporate travel bans, and lots of restrictions then started to be put on employees due to coronavirus. And many of the tech companies, for example, they've had they placed travel restrictions early on. Large festivals, mass gatherings were all canceled. And not the least were the medical conferences. So maybe we could pause a little bit and talk about any patterns that we see between those recent outbreaks and the recent situation.
Yeah, thanks, Lin. So I think you really covered the history really well. I mean, what lessons can we learn from the history? I mean, we've kind of always referenced the Spanish flu, and what's interesting, you mentioned about that, we're probably in the first wave. What have we got to, wonder about the second and possible third wave? Because from my understanding, the second wave was actually a larger morbidity mortality in the Spanish flu.
Right. So with the 1918 flu, as many people know, the flu virus can mutate very, very easily. So that probably led to some mutations between the first and the second waves, where it became more and more lethal. Can coronavirus do that? Can COVID-19 do that? So far, most of the genetic sequencing or the sequencing studies have found relatively limited changes. They can still use these genetic sequencing to identify where the virus came from, which strain, whether it came from China, for example, or Europe. And so we have so many more tools to nowadays to track the evolution of the viruses and how they are spreading compared to 1918. And we don't really know enough about this coronavirus yet to know whether there is a potential of a certain mutation or some mutations that will lead it to be even more dangerous. And so lessons learned with flu pandemic in 1918, they had sequential waves where the virus mutated and probably as a result of that became more, caused more fatalities. And so we have to watch what's going on with COVID-19, whether the virus is capable of evolving and leading it to escape either our detection or treatment or perhaps therapeutic interventions, and leading to even more fatal cases. I think having learned some lessons from the flu pandemic, we saw those waves back then. Here during the COVID-19 pandemic, we are seeing second waves, third waves, fourth waves in some countries. Singapore, for example, that controlled it very, very well initially. They've had additional waves, and now it's in the migrant population there. And so I think we can learn from the countries that are going through their second and third waves about who are the more vulnerable populations, what kinds of factors there may be, and how might we want to address it before it comes our way, and following a similar pattern.
And what is it about coronaviruses? I mean, in terms of, we mentioned SARS, which we saw SARS-CoV-1, and this is SARS-CoV-2. Why have we seen these viruses in particular? Well, are we going to come to that? Or is that
oh yes, a very good question. So I think the SARS CoV or the original one, 2002, 2003, it was back then. It was originally traced to civet cats, and then further work identified it to be associated with bats. The current coronavirus has been associated with bats, has been associated with pangolins. It was felt that it because of the connection with this seafood wholesale market, the name is actually it might be misleading. It's actually a wholesale market of exotic animals, not just seafood. And so there are many species perhaps intermingling. Perhaps the virus came from bats and then was passed on to another species, perhaps the pangolins. So I think we're still learning. There's still much to learn about this, but the suspicion is that there is the human and animal interaction and the intersection that allow this virus to jump from an animal source into humans. And when humans have not seen this particular virus before, it then can lead to a lot of disease, very rapid spread, and very widespread to all the vulnerable non-immune people. So,
okay, so the wet markets sounds like it's an issue. So we'll continue on, and then we'll ask them, maybe we can continue through, and then we could ask some questions. Then this is great. Thanks, Dr. Chen.
Okay, so then so as meetings and conferences and then travel were all being deferred or canceled or postponed. This is a CDC site as of mid to late March is when I copied this one, showed so many countries in warning level 3. that it simply couldn't count them anymore. And most other countries have also instituted similar kinds of travel restrictions, travel advisories, even if they were not specifically do not travel. They did started talking about deferring it. And as everybody knows, March 11th, the World Health Organization determined that this is a pandemic. And that led to widespread travel bans and restrictions on large gatherings. And this map that many people have seen shows the astronomical rise in this graph down on the bottom around the world. The first 100,000 cases were actually accumulated, reported over a 3-month period. But in the last few days, the last million were reported and recorded. So you can see how dramatic the increase has been. And to bring it closer to home for me, this was a report from Massachusetts Department of Public Health yesterday, and newly reported cases yesterday numbered 1,840. Confirmed cases number 58,000, and newly reported death yesterday was 150. Total tests performed in the state was about 250,000. There were over 3,000 deaths in Massachusetts from confirmed COVID-19 cases. And then hospitalized patients make up about 7% of the total. And testing has been a barrier in the United States, to be honest. We really would have liked to see identification or testing of any potential cases, isolate them, quarantine the cases to limit the spread. But there were a number of shortages besides the test kits having some issues. There were supply shortages like swabs and the reagents. So those shortages have hampered the ability to test as many people as possible. I think at this point that is now at a better status. And let's see, this is another illustration of the cases in Massachusetts for those who are interested. So we started seeing some cases about mid-March, and you can see the increase over this time. The bar graph seems to be declining, which is we're happy to see. For Cambridge, actually, Cambridge, as of yesterday afternoon or evening, had over 300 residents that tested positive, 43 confirmed cases, and 43 confirmed deaths, and 89 total recoveries. Many of these patients are still undergoing their disease course. And so what do we know about COVID-19 at this point? It's we still have very much to learn about this virus. It's a very stealthy virus, very stealthy pathogen. And partly because we have had some difficulty in identifying exactly where it is, who is infected. It is highly transmissible, and it's also stealthy because some people may be asymptomatic or pre-symptomatic and yet capable of transmitting the disease. And there have been many clusters that are reported, including some clusters in Singapore, Korea, as well as the US. And the symptoms can range from none at all to being critically ill. So the general breakdown is 80% maybe mild to moderate, 15% are severe, and 5% are critical. And the risks for severe and critical and fatal cases include older age. Some use 60, some use 65, but older age certainly is a risk. Cardiovascular disease, underlying cardiovascular disease is a problem. Diabetes mellitus, chronic respiratory disease, high blood pressure, cancer, and then more recently from Europe, Italy, the US, obesity has been identified to be a risk factor for severe and fatal disease. And then what do we know about the virus, SARS-CoV-2 itself, and treatments? We're still learning. The virus, many have seen this picture, just like the CDC, a photo with the spikes on the virus. It attaches to these ACE2 receptors on the host cell surface, gets into the cell, and then continues its way to cause the disease. So there are many, many drugs that are under investigation for SARS-CoV-2. I think there's none that is showing itself to be a dramatic cure. And then I found it very, very interesting in the case of the Diamond Princess cruise, where they had a really good test situation with 37 or so passengers and crew. Everybody got tested. About 1 out of 5, 19% to be exact, were positive. And nearly half of them had no symptoms at the time of the test. And then 18% of all those who tested positive never developed symptoms. So that's somewhere around 3 to 4% of the total population of the 3,700 or so that actually never developed symptoms. And then 381 had symptoms and also had positive tests. 10% needed intensive care treatment, and 1.3% died. But this was another illustration that older people have a higher risk of the severe or fatal cases. And the CDC has published an article about the outbreaks of COVID on cruise ships. There are many with passengers who then have disseminated to many countries. There are some that were kept at sea for quite some time before they can disembark. And we knew at the time of this publication that at least 800 cases of laboratory confirmed COVID-19 cases occurred during the outbreaks on 3 cruise ships. And the cases were linked to several additional cruises having been reported across the United States. And these cruise ships are actually present worldwide, so you can imagine the number of patients and countries that may be affected as a result of cruises. So in March, this was from The Economist, and it looks really appropriate for the times that the world has closed. The borders, the businesses, the schools, many schools in various countries have closed. Meetings, many activities are canceled. So maybe we can go back to that and think of and talk about the COVID-19.
Yeah, thanks, Lin. I mean, it's interesting, you know, especially with the experiment, a natural experiment on the Princess Diamond. And I think one of the big questions we have is, why do some people get no symptoms and some end up on a ventilator or even succumb to this illness? What are your thoughts?
Oh, I think we're certainly still learning. And so those risk factors were based on the pure number of patients who had those conditions. And then we're starting to see increasingly scientific data and about the perhaps endothelial dysfunction associated with COVID-19. We're learning about many cytokines, especially interleukin-6, that appears to be really triggered and go into overproduction. So there is an immune response. There is some endothelial issues. There's probably genetics. And then why are some of these diseases, why do some of these underlying health problems make a person more susceptible to severe disease? I think we're still exploring the answers. It's probably multifactorial. And then even with the findings in the lung, some people have really severe lung distress, severe respiratory distress, while other people, even though they develop shortness of breath, the cough, similar symptoms, but they're able to bounce back. And it appears that there's a little bit of, there are some differences between the lungs of these people. So what makes one more susceptible to the severe disease and the other one able to bounce back? I think all these are questions to be answered.
Mm-hmm. That's interesting. And when you showed the mechanism of the virus, you talked about one of the areas that's been discussed is about the attachment with the type 2 pneumocyte, the ACE into the type 2 pneumocyte. And right. Some of the initial data from China, some of these patients presented with abdominal pain or gastrointestinal symptoms, so much so they ended up on those wards. And from my understanding, some of those cells are located in the gut. So I was just interested, do you know, is there any thoughts about the mechanism of the way it's attacking the lung or the symptoms, and in terms of then looking at treatment options?
That I'm not really sure. And I think it's an area that's still under investigation.
Okay. Yeah. And when you look at the antiviral treatments, we've been told with the vaccine development, which we probably can go and discuss, is what is the timeline for some of those antiviral candidates?
So there have been some studies published on remdesivir, for example, which is one of the more promising antivirals, and relatively small studies, but there are larger INDs and larger clinical trials that are underway, and some are starting to analyze their data. So I think in the upcoming weeks, we should be hearing about some preliminary results. So far, the other trials, the smaller trials, have not been so promising, but I think we need larger series, larger clinical trials to give more robust data.
And just so for the audience, the differences between the vaccine and antivirals, the antivirals the person will have the disease and it will just shorten the duration or the severity. Is that correct? Right.
So the antiviral will be like Tamiflu, which is one of the antivirals that we use to treat influenza. And for influenza infection, for example, it works early on. So if somebody has a flu symptoms, say a week ago, but then still has some lingering symptoms, it's probably not going to work at that point. And this is felt perhaps to be a similar situation with remdesivir. It's an antiviral. It works on the virus. Ideally, if it can be, so again, these trials are underway, and they really need to sort out what's the best timing for using the antivirals. This is a whole new disease that we don't know about. And so some of the antivirals, you might think that they could attack the virus and clear it from our system. Then, because of these immunologic processes that the virus triggers, there's that other part, other component of the viral infection where it's causing the immune response to be hyperactive, so to speak. So some of those medicines are actually trying to moderate this part of the infection. Yeah. And vaccines, certainly if it's available, that works early on to prevent somebody to prevent the virus from attacking a person's cells to start. Now the vaccines, the last I heard, I think there are many candidates under development. Oxford appears to have the one that's made the furthest progress, and I believe they're talking about September as the timeline for them having some data at least. There may be data early on, but it appears promising.
Okay, that sounds fun. Did you have any more slides, or should we okay to keep talking? Or?
So we can go on to maybe the...
Yeah, just while we're getting the slides up, I mean, do you see with you mentioned the vaccine, do you think there are other coronaviruses that causes common colds? Do you think, is there a possibility that the vaccine will also cover the colds? I mean, I think a lot of people would love if that's the case.
Right. I think it probably depends on how the vaccine is made, but I think right now, all the vaccines are really directed at this virus more specifically. And you bring up a really good point, because there are 4 coronaviruses that have caused a common cold in humans. So let me see. Can you see the slide now?
Not coming up yet.
No. Let's see. All right. How about now?
Yeah. No, we're good now. Okay. Thanks, Chen.
Okay. So I thought we could talk about the travel issue, because as I experienced, it was tremendously challenging. January, February, March, and until everybody shut down. And early on, these were the first questions that we were discussing with the travelers. Go or no go? Is the travel or gathering of critical or essential at this time? So in January, people started hearing about this virus. They were not going to go to China anymore unless there was something critical going on there. But as it started to spread to Thailand, Japan, Singapore, more and more people started asking about the necessity to go, or is this a good time to go? And the other question we asked is there increased risk for severe COVID-19 disease based on your health background, so that individual's background? So people started thinking about this, started modifying their trips. I think a lot of the constraints were based on whether one can get airline to change, and how high these fees might be. I think we talked to a countless number of travelers who had to reassess and consider the economic loss or financial loss versus the risks. And then the next stage, as it spread, COVID-19 spread further and further, we talked about, is there community transmission at the destination? And if there is, how would that traveler deal with becoming sick or being quarantined there, or at the destination or in transit, because that could have happened in many situations. And then also, as we in the United States, some of the states started to identify cases, we started to ask, is there community transmission in your home community? If there is, might you be quarantined when you arrive there? And you might be sick there, be stuck in transit. And so how would you manage? So these were really, really difficult questions, difficult considerations for so many travelers. And then we thought about contingency plans. We tried to help people think about their contingency plans. What if you still decide to go today on your trip this weekend, but next week borders are shut down? How would you deal with that? And then how will the concerns about COVID-19 affect the trip, the enjoyment or productivity? So whether it's leisure or visiting family or going for business or education, what are potential implications? And then as we saw that travel was really shutting down and we started to talk about the quarantine and then social distancing, we started discussing the individual contributions to mitigate the impact of COVID-19. And certainly the fewer people who move around and who can do the follow the social distancing recommendations, the easier it is to try to mitigate the impact. And so on this slide are some of the more specific issues we talked about: the good hand hygiene, avoid touching face, avoid human-animal contact. These all came out early on from WHO, from CDC, from many national health authorities, and avoid contact with ill persons. And then as we started thinking more and more about this virus, even though initially it was felt to be just respiratory droplets, but we started to wonder, can it survive on surfaces? So additional recommendations were added about minimizing the touching of high traffic areas, wiping down seats in the airplane, tray tables, and try to keep distance from others of 6 feet. And then further on, the social distancing recommendations. So, so I wanted to show this slide because of the very important resources that we've all used during this time in the US CDC's guidelines, and then certainly WHO around the world. And then in the US, we also use the State Department travel site. So we joked a bit with friends and colleagues about 2020 being the year of deferred travel. And I think this is true for so many people. We, in thinking about how we're gonna move on when businesses start to open and travel starts to be allowed again, we really need very detailed epidemiology. We need that data. And this is evolving day by day, week by week, and things can deteriorate suddenly or have significant improve in, say, over a week or two. So it's very, very important that people seek reliable sources or consult reliable sources about the detailed epidemiology. And this would apply to the origin country, to the transit area, and to the destination. So it's quite a complex thinking. And then I think people need to think about medical care during the journey, whether there will be appropriate care, and then insurance is a really interesting area right now. There's trip insurance, there's travel medical insurance, there's medical evacuation insurance. But somebody told me that there was no travel insurance available. I can't remember where that person made the comment. And I think they must be altering their the coverage and availability given this immense challenge of COVID. And so contingency plans are really important because of the sudden cancellations that might happen. And then follow advisory. So if New Zealanders are listening in on this and live in the US, CDC's resources, advisories are very easily accessible. The State Department, if you have US State Department support, that's another source of really good recommendations and advice. So I'll just quickly talk about travel medicine expertise for the future. This is actually from the World Tourism Organization early on this year, and the trend was supposed to be going up like that. But I think we're going to be seeing something like this dip, gigantic curve, dip in the curve before it goes up again. But I'm optimistic that travel will resume. People will still want to travel. I think there are so many lessons learned during this pandemic. As far as travel volume goes, there were over 1.4 billion international tourist arrivals in 2019. And we were supposed to go up by 5%. It will be interesting to see what that turns out to be. Perhaps it's going to be minus, I don't know how many digits. But I think this will recover because people want to explore, people want to learn from the rest of the world. People still benefit from person-to-person direct contact. And then some of the issues that we've been thinking about in travel medicine over the last few years is actually the impact of environmental factors and climate change on travelers, and the impact of travelers on the environment and climate change. So a silver lining from this pandemic is that different areas have reported cleaner air, less pollution, certainly no traffic or improved traffic. And perhaps the strain on the environment is reduced. And it will be interesting to see whether analyses will be done on that. And but going forth, I think travel medicine will need to also think about the Sustainable Development Goals from the United Nations that would also apply to tourism and travel. So I think travel is a global phenomenon. It affects everyone, and I think we can see that it's affected people going going for business, for commerce, people who are traveling for education or research, humanitarian relief, to visit families, to attend meetings, conferences, or religious gatherings. And then the recent emerging infections have all rapidly disseminated in our interconnected world, and COVID-19 definitely illustrated that. And it has spread very stealthily around the world, as we can see. So COVID-19 definitely has profound impact on travel, and we'll definitely continue to think about it because tourism remains one of the most powerful drivers of economic growth and development. So I think it's still, for the recovery, for the economic recovery, it's still a really enormous factor to consider. So I mentioned the silver lining about the air pollution, air quality, traffic, and perhaps families might have more closer connections because now they're home, perhaps doing some homeschooling as well as the virtual lessons. And I think technology definitely has, for virtual meetings, has jumped ahead. These lectures via Zoom and other platforms probably would have taken a lot longer for people to adopt if it hadn't been for this pandemic. And telehealth also is has made advances during this COVID-19 pandemic. So then, and I wanted to share the International Society of Travel Medicine because this is the international organization. It promotes healthy, safe, and responsible travel of all people crossing international borders in cooperation with healthcare providers, academic centers, travel industry, and media. The society advocates education and service and surveillance and research in travel medicine. And we focus on illness and injury prevention, but also diagnostics and therapeutics, with attention given to the understanding, impact, and modification of environmental, behavioral, or host factors on travelers and migrants and refugees. So in the end, we think of travel as something that impacts all population that is moving. And it's not just for tourism. It really involves migrants, population migration, and includes the refugee health as well. And our website is istm.org. So I would welcome any your exploration there.
That's really fantastic, Dr. Chen. Probably there's a couple of quick questions before we end. It's a fantastic presentation and a great resource for everybody. Really appreciate your time in doing that. I mean, the future of travel, I mean, do you see us being a little bit more sustainable with the way we're traveling?
I think people will think more about it. And the sustainability of travel, how can we improve or reduce our impact on the environment? And so that was actually the theme in the last international conference that was held in June of 2019. And we have a task force looking at this particular area, how to adopt the UN Sustainable Development Goals, how to reduce environmental impact. And I think we started thinking about how can we help travelers or sort of remind travelers how we can travel in a more sustainable way, and how can we make our activities more sustainable. And I think a lot of these virtual platforms for meetings, for conferences, for educational programs will be will be very important in the future.
And you're based in Boston or Cambridge, Massachusetts. Can you tell us a little bit about your maybe personal experience with COVID, just in the community, or how's Boston holding up?
I think the around mid-April is probably when we saw the major surge, and I remember hearing the reports that Boston Medical Center, for example, their intensive care unit was full, and that some other major hospitals in town were also approaching that. And I think in our own community, I have to say that the preparations were exemplary. It's something that we've never faced before, but I think everybody came together, and everybody was interested in how can we limit the spread, how can we contain or mitigate the impact. And I think people really worked hard to flatten the curve, so to speak, and hope that we by ourselves sometime. I think people realize that there will be additional waves as things open up, but if therapeutics have better data and vaccine development is further along and potentially available, it will be in a better shape. So I think that's another thing that I've seen is how people really came together, and people's roles in the hospital, for example, have all changed. People were assigned to different tasks. Things were repurposed. People's roles were had pivoted. So there are many adjustments to be done, but I think our community really came together.
Well, that's great. Great to hear. Well, we really respect your time, so we'll probably just end it. Do you have any other final comments for the audience at all?
I think I'd be curious to hear New Zealand's situation. It's amazing what you've done there. Sadly, I could not go, and we had actually.
Hopefully next year we'll get you over to speak. So Dr. Chen was going to speak at the International Society of Travel Medicine, which he's the president of. So we'll have to get her over to New Zealand for that. Yeah.
And one of the executive board counselors, Dr. Jenny Visser, is in New Zealand. So we collaborate a lot, interact a lot. So we hear of the progress in New Zealand, and
yeah, no, we're. I think people are doing a good job collectively. I think it's difficult. I think internationally, just with those big decisions about shutting borders down and restricting. We're now we've gone from lockdown 4. A 4 level to total lockdown to level 3 where it just started. So is Boston under sort of a lockdown measure at the moment, the state?
We are still staying at home through, I believe, May 18th is the new the goal, and it'll be reassessed around that time. And so schools are closed, businesses are closed, people are working from home. And I think we'll have to see how things open up. And actually, Cambridge and Somerville, both these 2 cities have announced mandatory wearing of face covering when out in public. So, and the goal is to hopefully minimize people who might be carrying it to spread it to others unknowingly.
Okay, that's interesting. And is the mask available, or is this like surgical masks or cloth masks?
Cloth masks, bandanas, scarves, basically covering would be sufficient. So it's not specified that it has to be a manufactured type of mask. So I would say bandanas, and a lot of people have been sewing cloth masks.
Yeah, no, that's good. Okay, well, that sounds great. So you mentioned the website for International Society of Travel Medicine. Is there anything else? I mean, you publish a lot of work. Is there anywhere else that people could follow you or the work of your society?
Oh, absolutely. So the society's Twitter handle is @_ISTM_. My Twitter handle is @LINHCHEN. So happy to and welcome other people to follow us.
Oh, that's great. Well, Dr. Chen, thank you for all the work you do in Boston and in America with the CDC, publishing and internationally. And we really appreciate your time, and we look forward to having you in New Zealand, hopefully next year when this dies down.
Thank you, Xaviour. Thank you for the invitation. It's my pleasure.
Thank you so much, Dr. Chen.